And thanks for joining. My dog decided to bark just now. Hold on a second. Okay, so thanks for being here today. We are going to, as usual, start off this presentation with a pre-poll so we can measure before and after for this COVID-19 grant. So if you would be so kind, I will launch a poll. And if you could fill that out, that would be lovely. And it should be up. So I'll give that a couple minutes. Okay, thanks. I see the results coming in, so I appreciate you filling that out. As you continue to fill that out, we can get started with introductions. So let me share my screen again. Okay, so today we have Dr. Katie Mang-Smith here to talk to us about the COVID-19 pandemic and the perspective from a rural hospital in terms of caring for perinatal patients. So this is the fourth webinar in the COVID-19 in the perinatal population webinar series, which is funded by CDC. And again, we will get started, and please stay on if you can through the end of the presentation, because we will have a post survey that we ask you to complete, again, for our grant reporting purposes. And then also we do have CE that you are eligible for at the end of this presentation. So we'll share a link to that CE at the end as well. So I'll keep that poll up for a couple more minutes, but with that, we can welcome Dr. Katie Mang-Smith to share her screen and say hello.
Okay, thank you so much, Katie. So I'm going to talk today about perinatal health during COVID-19, kind of from our perspective, from a rural hospital. I'm a generalist OBGYN in the Western Slope. And I know a lot of the things I'm going to talk about, I think we all went through and all experienced. It wasn't unique to us as a rural location, but just to kind of give you an idea. I have no financial disclosures, unfortunately. So the objectives are pretty basic, just to relay unique issues that arose in perinatal health in rural Colorado, discuss solutions unique to this situation, and then just to review 4 different cases of patients that highlight different issues that we had with COVID. So this is our beautiful state. And if you look, this is where I live here. And kind of going in a little bit closer to the area that we serve, up to Meeker, some patients from Craig, since Craig closed their hospital, Eagle, Edwards, definitely for sure, Aspen, Marble, Redstone, that's kind of where we serve. And Glenwood Springs has about 10,000 people population. The area we serve is definitely bigger than that, but right here, if my thing will come up, this is Glenwood Canyon. And if you guys are not aware, Glenwood Canyon is about the only way to get to Denver, especially during the winter, that doesn't take hours around. And that canyon seems to make us more isolated than just about anything, because it closes not infrequently for fire, rock slides, mudslides. Anytime there's a threatened storm now, they are closing it because of the people that were caught in the canyon last year. The highway itself closes many times due to accidents. And so it makes, although we're only about 3 hours away, it sometimes feels quite a bit further. Also difficult for us is the weather patterns here. For example, last week we had a patient with a hypertensive crisis, preeclampsia, and there was a storm around, which comes every afternoon, and we were unable to fly that patient out. So feels pretty more isolated now sometimes than it even did before. I think another thing that's kind of unique about our area from the Front Range is that this political environment here is a little bit different. It feels a little bit Wild West sometimes, definitely kind of an anti-government feel and Republican country. And that shouldn't impact health, but interestingly enough, during COVID, it did, especially for vaccines and care. So that's kind of where I'm coming from. I work for Valley View Hospital. I'm hospital employed. We're a nonprofit independent hospital, which I think meant a lot during COVID. There are other rural hospitals, but a lot of them are associated with larger organizations. And with those organizations, you know, comes a lot of experts and policies and support in numbers that we didn't really have. We've served our community for 75 years. We are a trauma level 3 and a NICU level 2. So if you remember, trauma levels, like 1 is the highest acuity care, and NICU it's 4, they're the opposite. We have 78 beds, 10 ICUs. We do about 700 deliveries a year, give or take. And we're staffed by OBGYNs and certified nurse midwives, CNMs. We have pediatricians available to us. We have a hospitalist service that's in the hospital 24/7, CRNAs and anesthesiologists. So I think the biggest thing about COVID and living in the rural area is that resources are just incredibly limited. We have no ID doctor, no specialists, no big teams making decisions. And again, there's that comfort in numbers. So when COVID hit and we weren't getting a lot of input from other places, it left us a little bit feeling on our own. Definitely staffing is a real limited resource in the rural area. Like in 24 hours, we lost 25% of our OB staff who tested positive for COVID. And when you're in a bigger facility, it's a little easier to cover that. Patients are still the same. So when you lose so much staff, it makes it really difficult. We were short on PPE, I think like a lot of places, but didn't have the ability to draw from other places around us. And then unlike kind of the Front Range and the health department presence for testing, for vaccines, all of that stuff, we didn't have that. And so everything fell to the hospital to organize and distribute. And that's hard when you have a smaller facility. Let's see. Those are kind of the biggest thing to understand is just feeling isolated, feeling alone, and just having a real lack of resources. For example, I don't know that this is unique either, but this is from our local paper where Valley View nurses prepared for COVID with sewing machines. And this is a picture of that. And basically when the hospital kind of shut down, this is what a lot of our staff did to try to help with our PPE shortage. In fact, even our plastic surgeon came down to try to help, although we found she's not very good with a sewing machine. So I think she provided just more entertainment than anything. So like I mentioned, kind of everything fell to the hospital to do. And so for a while, we were the only place to get any testing done. And so we had to organize who could order that, how to get patients through, who's going to staff it, how do we do it safely. And in our town of 10,000 people, we did almost 23,000 COVID tests during the height of COVID, which is a lot of patients and a lot of people to get through. And in fact, we were using microgen for a little bit to do our testing. And there was a point where there was some concerns about the standard of care for microgen. And so we decided to end that relationship and didn't have anywhere to get our tests done. And so because our CMO had some relationships at Children's, we reached out to Children's and they were actually able to handle our tests and take our capacity. We got results a lot quicker. But if you look at Children's Hospital EMR and you see a 78-year-old male, it's probably from us and their test results. In terms of vaccination, again, only place to get vaccinated was at the hospital for a long time. And for example, our pharmacist would get, our head pharmacist from the hospital, he would get to the hospital at 4 a.m. and get the vaccines rolling, and then he would go do his regular job. And the vaccine clinic pulled about 20 to 25 people, a lot of our staff. Some were volunteering, some were just pulled from the hospital. All of our administrators were there during the vaccine clinics. And we gave almost 28,000 vaccines. Again, that's a lot of people to organize, get through the hospital. It's just a lot. And there's just nowhere else for people to go. So it kind of fell to us to do that. Also, from an education standpoint, a lot of our staff were consultants for the local school district, gave interviews for the paper, sort of all that education standpoint too, to the schools and to parents and stuff, fell to our physicians to kind of take care of. Also, like meeting with the mayor, different things like that. So during COVID, it really forced us to create these relationships that we hadn't previously had, especially for our higher acuity kind of things. So we had an ID specialist that we could consult, but no like relationships with the bigger organizations from a larger standpoint. And so kind of to give you a little bit of a funny story, our CMO, certified, our chief medical officer, he is a pediatrician here. And he happened to be in Denver at CU. His dad, unfortunately, had to have bypass March of 2020. And so that's when everything kind of hit the fan and we just didn't know what we needed to do. And so he actually snuck into incident command at the University Hospital and then at Children's to kind of see, okay, what are they doing? What are they talking about? How are they going to do this? And I think eventually they realized he probably shouldn't be there, and he introduced himself and got phone numbers, and that's actually how we got a lot of our protocols, a lot of our things that happened during the COVID was because he had those relationships. So definitely for our higher acuity centers. And I know CU and Children's really stepped up during the pandemic, but at the beginning it took some time. Also from a lower acuity standpoint, so we have a kind of a competitor hospital that's about 45 minutes away from us, Aspen Hospital. And there became this agreement just to kind of optimize care, to redistribute complexity. So they would take some of our lower acuity hospital patients, and because we had the ICU capabilities, we would take their higher acuity patients if it got really tight in our community. And then this came along, the mandatory vaccine, and this is also from our paper. And I know this was a big deal for a lot of places. It was a really big deal here, lots of protests, and actually estimate we lost a few providers, and estimate we lost about 15% of our NICU and labor nurses. And doesn't sound like a lot, but at this point, the staff is really, really burnt out. They've worked really, really hard for a long time in a really stressful situation. And then, you lose 15% of your staff. There's nobody else in the community who can do that job. That's it. We can't pull people in. And so it just made it even more stressful for the staff, especially at the beginning. They're trying to cover all the shifts. And then, something I wanted to kind of point out, I read a lot of articles about how the science of COVID, how COVID affected pregnancy and breastfeeding and babies and stuff. And I think a small percentage of our patients really had severe COVID where it really, really affected them. But 100% of our patients experienced kind of this toll on COVID. And I think we don't appreciate what that really felt like and the implications for that. But I read this article, it was in our obstetrics and gynecology, our green journal, and they tried to do a study kind of identifying that, and I really respected what they did. But within that article, it talked about some like themes that different moms had and important stressors. And the toll of the fear, fear of what if I get this? How will this affect my baby? How will this affect my ability to deliver? Should I have people visit? Should I have people not visit? Should my mom come and help me out, or should she not travel? Just that overwhelming fear. Also, I think the loss, so the loss of that time, the ability for family to come visit in the hospital, older kids to be able to visit, the loss of the community that goes along with having babies. People were in and out of the hospital really quickly, even within 24 hours leaving. And I think there's just a lot of that social part that got lost. People feel very, very isolated. And I think all of us felt that. I do think that is potentially a little bit more difficult in a rural community where there's just less people around. Childcare was really difficult. Employment, having older kids was really stressful for a lot of new moms. A lot of moms, never got that break for the kids going to school, and they had to try to be the teacher for their kids. And I think that added a lot of stress. Also just, older kids being out in the community and bringing COVID home. Could I get it when I'm pregnant? And could, the baby get sick, and sort of the stress related to that. And then I think the rapidly changing guidelines and guidance also created a lot of stress for new moms. They pointed out what was really lacking during COVID was the ability to have any self-care at all. The interpersonal relationships with friends, family, you name it. And then just the structural support that was there. For example, we have, a lot of different lactation consultants, different things, community-based intervention for new moms that try to help, especially our at-risk moms. And that all kind of went away for a while. And I think that was a huge toll on our patients. So you can kind of look at the numbers all day long, but I don't think it really tells the story of what COVID was like for moms and families, et cetera, like cases do. So I wanted to go into 4 cases that really highlight different aspects of COVID. So the first one is kind of the most obvious one, someone who's really ill from COVID. So, oh, I forgot this picture. Sorry, this is the picture from that article. And I liked it a lot because it shows this mom with her newborn trying to be this kiddo's 2nd grade teacher as well, trying to manage both of those. So this first patient, she's a 45-year-old G4P3, which means she's had 3 full-term deliveries, although they were about 20 years before, who had a very high-risk pregnancy. She had IVF done in Mexico, for which I had no records for. She was Hispanic, Spanish speaking only, probably a pre-existing type 2 diabetic. By the time she got to me for prenatal care, she was on metformin from the fertility clinic for reasons we weren't clear, and switched over to insulin pretty quickly, and she required quite a bit. So I think probably a type 2 diabetic. She'd had a previous nephrectomy. So her kidney was removed as a child for congenital issues and multiple infections. And then she'd had multiple abdominal surgeries, which became really important during her delivery, 2 C-sections, and then a myomectomy. So they done a C-section incision and taken several fibroids out of her uterus, which means that she could not labor at all. There was a really high risk of uterine rupture because of that. She'd also had the nephrectomy from anterior approach and a tummy tuck, an abdominoplasty, so lots of surgeries. She was obese, hypothyroidism, and then she had emergency services only, which if you're not familiar with that, that's a lot of our undocumented patients. And so, sorry, 1 second. And so that doesn't pay for prenatal care or labs, ultrasounds, and those things can add up over time. So she's about 32 weeks pregnant. The first day she has symptoms, which is a headache, a cough, and a low-grade fever. We got her tested that day, and that was at the point where we weren't getting test results right away. So it wasn't until day 3 that she came back positive for COVID. On day 4, she presented to our emergency room with shortness of breath, decreased intake, abdominal pain, and cough. When she got there, she had abnormal vital signs, so she was tachycardic. She was complaining of really high levels of pain. She also had evidence of multi-organ involvement, so her liver enzymes were abnormal. Her creatinine involving her kidneys was abnormal. She had some pretty significant acid-base issues with a low CO2. She was diagnosed with COVID pneumonia, and some pro-inflammatory agents that are important in identifying people who may be at risk for severe COVID. Those were pretty elevated. But she was discharged from the emergency room after getting about 2 liters of fluid, Tylenol, heparin, because we thought she was at increased risk of blood clots because she had COVID. She never, unfortunately, got that filled. And then she was diagnosed with a urinary tract infection and was placed on antibiotics, which was concerning with the one kidney. So day 6, so that was day 4. 2 days later, day 6, she presented to the emergency room. We had actually called her because we were trying to call our patients who had COVID to check in with them. And we had sent her to the emergency room because of the complaints that she had. And I think, we kind of lost track of when she went and if she went, and we never got consulted that day, which I think was a missed opportunity to intervene in her care. But she came in with chest pain, a cough, shortness of breath, and nausea. She was again tachycardic, but now having some hypoxia, so her oxygen levels were dropping with exertion, and she had similar lab abnormalities, so liver, kidney, acid-base issues. A CT angiogram was done to kind of rule out a PE, and she was given IV fluids. The notes say she was offered admission for observation. I think the patient and the family felt like that wasn't really offered to them, but that's in the notes, and no OB consult. And at this point, kind of looking back, you're like, gosh, why didn't they admit her? She clearly is very high risk. She seems very ill. She's kind of going downhill. I think important to understand at that time was that our ED, their threshold for admission, because the hospital's full of COVID patients and people are dying and people are very, very sick. And so their threshold was, unless they cannot maintain their oxygen level on several liters of oxygen at rest, we're not admitting them. And so she got discharged again. So I know there's some non-medical people here, but this is a picture of her chest x-ray the first time she was in the ED. This is right after delivery, so when she actually got admitted. This is the CT angiogram, and this is supposed to be all black, or mostly black, and so all this white haziness, this is consistent with COVID pneumonia. And from the CT scan, you can see how much of her lung volume is really affected, and it's a lot. It's really impressive. As a generalist OBGYN, like, you see this and you're just like, oh my gosh, like warning signals going off big time. So day 7, she comes to the office, and we're trying to see our COVID patients at the end of the day, full PPE. And so she comes into the office and she's gasping for breath. She's falling over when standing, and she's complaining of contractions. And so since sending them to the ED didn't work for us before, we decided to actually admit her to our family birthplace, which is our labor and delivery unit, and ask the hospitalist to come to us. And I think, looking back, we just didn't feel comfortable managing these complex COVID patients. And so we were kind of trying to push the patients towards the hospitalist team, and that didn't work well for us. So from then on, we started to admit our patients to our unit and have the hospitalist come to us. But here are vital signs, a little bit abnormal. They didn't write down her respirations, but very shortly after she got there, I saw her and they were above 40. So she's breathing very, very, very fast. The nurse, I think, was just really scared of her appearance, and so put her on 3 liters, even though probably didn't need that much, but she was at 98%. This is what her fetal heart tracing looks like when she was admitted. She is having some contractions. Again, that's not great for someone who's had multiple uterine surgeries, but baby overall looks really actually reassuring, considering the way that the patient presented and how ill she looked. So she was 33 weeks and 2 days at that point. Respirations were above 40. And when I went to see her, she just kept telling me how tired she was, that she couldn't keep breathing like this. She felt like she was dying. And it was a really difficult, well, it's not anything a doctor wants to ever hear, but this is all through translation to a Spanish speaking only. And I'm going to show you what I looked like at that day, but trying to speak with someone when you're in full PPE with our little iPad next to us, who's translating to a patient who can't hear you is so sick they can't. I mean, it's just kind of a really difficult situation. So the patient actually called her niece, who spoke English, and just gave me the phone and said, listen, just tell her what's happening and she'll tell me what to do. And so that's what I did. During that time, the hospitalist consult came in and they said, we'll give IV dexamethasone. We didn't have any of the antivirals or IVIG or any of that at that point. We really didn't have much of anything. Her labs came back with multi-organ failure, and her troponin was really elevated, and troponin is a sign of cardiac stress. So none of this is very reassuring, and she's in severe respiratory distress. Finally got an ABG, and I'm not going to go into it in too much detail, but basically pretty concerning for how this patient is doing. So when I had this patient, it was in a snowstorm in the middle of winter. And so there is no way that I can get this patient transported anywhere just because of the weather. Even if I felt she was stable to be transported, it's just not a possibility. And so I called our MFM consultants in Denver, and they are wonderful people who answer the phone whenever we call. But it's a really difficult situation for them, I think, to never see the patient, never really see the labs, see all the things, and try to give us the best advice they can. And so this particular MFM felt like the mom's situation was really unstable, and that maybe delivery could help the mom, as well as that was not a good situation for the baby to be in. So she recommended delivery pretty immediately. And so I consented her for the C-section as best I could. I did ask for another physician to be there, and unfortunately my partners will always come in and help just because of our multiple abdominal surgeries. And I knew that she could not maintain her airway with regional anesthesia. Like most of our C-sections are done under, I mean, there's no way she could have even laid flat. She was just absolutely in complete distress. So we elected to do general anesthesia. We're lucky we had both a CRNA and an anesthesiologist that were able to come and kind of help with this patient. Unfortunately, we found out that we did not have the correct instruments that we needed to intubate a patient with COVID on family birthplace. That was the first time this had happened. And so there's a little scrambling to get the appropriate gear. We rectified that after this, but that kind of highlighted that maybe we weren't prepared for all the situations that could come up. Unfortunately, her C-section went really good. She only lost 500 cc's. We were able to get to the baby pretty quickly within a minute, which is, for those of you not medical, when you give general anesthesia to a mom, you're really trying to beat that general anesthesia to the baby because you don't want the baby to have respiratory depression. And so we do those in a really rapid way to get to the baby. After delivery, the mom was transported to the ICU. This is the cord gases from the baby, and surprisingly, although they're abnormal, especially the base excess, kind of getting close to 12, really didn't look that bad considering how sick she was. So as I was saying about trying to use the translator phone when you are in PPE. So this is what we look like. And a lot of us have 2 masks on at that point because we're trying to cover our masks to keep them clean. And so try to imagine what that really is like when you've got a really acute situation and a really sick patient. So baby boy was delivered. His APGARs were pretty good at 7 and 8. He weighed 5 pounds 9 ounces at 33 weeks, which kind of is explained by his mom's diabetes. Glucoses were a little low. He was on CPAP, had some concerning signs in his chest x-ray, not atypical to a baby born preterm, some hyperbilirubinemia, which is also sometimes associated with diabetes. But amazingly, this little kiddo was discharged in the hospital day 18, which was really great. However, both of his parents had COVID and he was in the NICU. And we don't have a special place to put our NICU babies or babies with moms that have COVID. And so those parents couldn't come in to see the baby. And that was really hard for I'm sure everyone involved. So mom went to the ICU, and I really do believe that this could have gone either way. We're really lucky she made a full recovery. I think she could have not. But that night she got really severe acidosis and was on a bicarb drip. But amazingly, by the next day, she really quickly recovered and actually was discharged to what we call motel status. So the patients are still in our hospital in a room, but they're not active patients at that time. She was discharged on hospital day 4. But all of her lab abnormalities started to correct, and she started to look pretty good. And so in this case, you know, delivery really did potentially save her life. And thankfully we weren't at 24 weeks when we had to do that, especially since we were kind of isolated in our ability to get this patient to more care. So that's the first patient, the most obvious, infected with COVID, very severe COVID, life-threatening situation. This is kind of a different patient who had COVID. That kind of highlights a different scenario. So she's a 26-year-old. She's her first baby. She's 40 weeks and 5 days. She presented in labor, and so she's in active labor. She'd had really limited prenatal care, especially in the U.S., which is not uncommon for our patients. And she came in and originally denied that she had any symptoms of COVID, but eventually tested positive. And this came up for us a lot. She had denied symptoms, even though she had a headache and a sore throat, because she didn't want to admit that she had symptoms or that she could be sick. I think, you know, fear of how we would treat her, how we would let her partner in, just being very scared that you're pregnant and you have COVID. So we had this a lot come up, not only in the hospital, but also in our clinic, where people didn't admit that they had symptoms before they came to see us. So we had full PPE outside of her room. And whenever we had COVID patients, especially along that time, we really tried to limit the amount of staff that were in the room. So we kind of had the same nurse, same provider in those rooms, really limiting any exposure that we had, especially because, you know, staff gets COVID and it's pretty tough. They're isolated and can't work for quite some time. And again, Spanish speaking only, all going through a translator in full PPE. So just to kind of highlight what that situation looks like. So stage 1 of labor, so getting to completely dilated, progressed relatively normally. She was down to be 10 centimeters and started pushing. She pushed for about 3 hours, which is not uncommon for a first-time mom who has an epidural. And the head delivers, and we see what's called a turtle sign. And that for you non-obstetricians is diagnostic of we're going to have what's called a shoulder dystocia. So basically the head delivers, the shoulders do not. And it is an absolute emergency. And when we have a shoulder dystocia, normally we hit our panic button, essentially, and we can get 5 or 6 staff that convene in the room in about a minute or less to help do the maneuvers that we need to deliver that baby. And to be honest, a shoulder dystocia is probably the thing that scares me the most as an obstetrician. Those emergency situations can be really scary. But when we called for help, the staff that had to get in there, they had to get in full PPE. And so nobody was recording because it was just the 2 providers in the room trying to deliver this baby, but maybe about 5 minutes to get everyone in the room, including the pediatrician, because after a shoulder dystocia, these babies, you know, they're very affected. They don't like to breathe. And so that was kind of a scary situation where a patient had COVID, had some symptoms, wasn't really sick, but had sort of the routine OB issues that can come up. And because of COVID, really delayed appropriate care for her. And so I think that was kind of another thing that kind of affected our patients as well. Okay, another picture of what we look like trying to do all this and why it takes so long to get into the room. It definitely takes a long time to get all this gear on. My third case is kind of how COVID affected families, not necessarily the patients having COVID, but what it was like to deliver a baby during this time. So this is a 35-year-old G2P1. She's at 30 weeks and 5 days. She has a history of a full-term delivery, and she PPRON, which means she broke her bag of water really early at 30 weeks. And so those patients we do not keep. Our NICU doesn't go down to that level. And so she was transported to Press St. Luke's in Denver, where she stayed for about 2 weeks, and then started having the baby's heart tracing didn't look good. And so she was taken for an emergency C-section, got our tubes removed as per her request, and delivered her son. And if you think about it, at that time, COVID, no spouses are allowed in the NICU. Her partner was actually trying to work here and manage their toddler, who was here. There's no kids allowed in the hospital. And so she was really by herself. And so if you really think about what that would feel like to be at a hospital you don't know, with providers you don't know, in a really scary situation where something's very wrong with the pregnancy, you're pretty preterm, and then baby's heart rate starts to tank, and you have to have this emergency cesarean section. And just imagine doing that all alone. And I think that is just I can't even imagine how difficult and scary that was. Fortunately for this patient, the baby stayed for about 3 days, and we were able to back transport the baby, which we try to do when we can, to get those patients back to our community, because this is where they're at, this is where their kids are, this is where their partners are, this is where their support often is. And so we were able to back transport that baby. Also, especially in this particular situation, that patient's partner was one of our pediatricians, and we really needed him to work. We really needed him here. And so fortunately, his son stayed in the NICU for 3 weeks, but if he hadn't been a provider in the NICU, he wouldn't have met his son for over a month. His wife didn't see their toddler because she couldn't come and go from the hospital at all when the baby was in the NICU, and so she didn't see her toddler for over a month as well. And so imagine kind of how that affected that family dynamic, and a time when it's supposed to be a really happy time, and just being separated, and all the stresses related to trying to deal with this situation. So I think very, very stressful. And then the last patient I wanted to talk about is not necessarily a perinatal health patient, but it is, I think, highlights what we really lost when we shut down. And that was a lot of our preventative care. And so this was my patient, and this one affected me pretty strongly because the patient and I are the same age. Which is always really hard as a provider to just kind of be the same age as a patient who's really sick. But she was a 41-year-old. She had 2 very young children, presented to our emergency room with vaginal bleeding. She had said that she had had a PAP prior to COVID, but was trying not to go to the doctor. And then she had been bleeding pretty heavy for a month. But at that point, the hospitals were full. There was a big surge in COVID. And so she was trying not to come to the hospital, I think for fear of, being a bother to us, as well as, could she contract COVID in the ED with all these sick patients. And so it took her some time to present for care. When she got there, her hemoglobin was 7, which is pretty low. And she's tachycardic. So the ER consulted me. And so I went to do an exam, and there's this big friable, so bleeding mass coming from either her cervix or her uterus. And, I know immediately this is a cancer. And so I come out and I consult, try to get this patient transported out to CU, where they have gyn-oncologists who are specialists that can surgically manage this patient. This is not a patient that I should be taking care of. And if she were to open up and really aggressively start bleeding, I was very worried about my ability to really help her, and that would have been very difficult. But CU, and in fact, all the hospitals, nobody's accepting any transports of any kind because they are so full of their own COVID patients. So I can't get this patient anywhere. I consulted one of the gynecs that works at CU, and she was wonderful, worked really hard to try to get my patient there, doing the best she could from her side. But she recommended that I do a biopsy to get the pathology going and to image her and to see how extensive this was. So I went to consent this patient for a biopsy, and she can't sign the consent. And I'm in Spanish, of course, theme here, trying to figure out why that is. And her friend who comes in to come back with her, because at that point we weren't having any of the other people in the ED, we asked for a friend to come back. And she said, yeah, she hasn't been able to text for the last couple weeks. She just kind of gets confused. And that, of course, like warning signs in my head. And so we did a CT of her head, abdomen, pelvis, and she had several metastases in her head. And that's why she couldn't sign the consent. And so this situation is even worse than I initially thought. So I admit her to the hospital because we can't get her transported, and start transfusions, pack the mask, trying to hold pressure on it, trying to do anything I can to prevent her from really starting to bleed. And because she has these brain mets and having neurologic symptoms, it was kind of our workaround that they were able to accept her into the neuro ICU, not the floor, but the neuro ICU. And so they would accept the transport. It still took a couple of days to get it all coordinated. She went by ground. And again, during that time, I'm really sweating it, hoping that she doesn't get too sick. But once we were finally able to transport her, she had a massive stroke en route. And by the time she reached the hospital, she had no upper brain activity, and she died. And so had we not been in COVID, had we not had this fear about people coming for care, could this have been a different outcome for this really young mom? I think it's definitely a possibility that we could have saved her life if the situation was different. And so this is just an example, I think, of a lot of patients who delayed care, and it really adversely affected their health. So that is my presentation. Excuse me. Special thanks to our CMO, Dr. Brooks, who helped me a lot with kind of how our hospital managed a lot of this stuff. Our staff, who have worked endlessly during this pandemic, really stressful situations, and for the patients who let me tell their stories to give you guys that experience of what we have. So thank you very much.
Thank you so much. If anyone has questions, there is a Q&A button on your Zoom where you can enter questions. So feel free to do that, and I will answer them. I have a question.
Yeah.
Once vaccines were available, obviously, you brought up the vaccine hesitancy, like among staff, about mandatory vaccinations. When you were talking to pregnant or postpartum patients about vaccines, did you also see that reflected in those patients?
Definitely. I mean, I think we probably have some of the lowest COVID vaccinated pregnant patients in the state. And that became very difficult. People were pretty upset. We still recommend the COVID vaccine to all of our pregnant patients and try to highlight the benefits. But at this point in the conversation, most people just stop listening. They either will do it or they won't, and they just stop listening and get kind of offended. We had a hard time. I have an outreach clinic in Silt, Colorado, which is even more swings that way, and getting patients even to wear masks into our clinic was pretty challenging sometimes alone. So yeah, unfortunately, why this whole issue became so political, I'll never really understand, but it did really affect our care of patients here and how, what we could do, how they received our recommendations,
Yeah.
unfortunately.
Was there any like tactics you used it in those encounters that were successful?
I mean, motivational sort of talking to patients is a skill we all really work on, and sometimes it works and sometimes it doesn't. You know, fortunately where we live, the Hispanic community actually really had good uptake of the vaccine. I think that for whatever reason that was, those patients seemed more open to our suggestions. Do I have any like telltale signs of how I can talk someone into the COVID vaccine? I really don't. We just try to share the scientific information, try to make it about the health of their baby, their health, you know, sometimes give a little bit of personal situations of the patients that were really, really sick that we did take care of, and how that affected their pregnancy and their babies. And you know, a lot of times patients, when they hear a story about another patient, especially in their community, they can relate to that better than me quoting this, like this percentage of people, you know,
Yeah.
I don't think that hits patients quite the same.
Yeah. Have you seen any of that change now that we've had vaccines for over a year?
Not really. I mean, at this point, getting boosters, I think, is a little bit easier to talk patients into than getting the vaccine if they have not had it. I mean, here it is such a decisive thing. I don't, you know, I know it is everywhere, but here it really is. And so there's not a lot of people we can sway.
Yeah. Well, we don't have any questions. We have a couple of comments. Nick says, great job, Katie. Anya Peterson says she doesn't have a question, but just wants to thank you for sharing the powerful stories of your patients. Yeah, but if no one has any further questions, I will launch the exit poll. If you could please take that, and then after that, I will show you the QR code for the CE. Okay, so that exit poll is launched. And yeah, I echo that the cases are very powerful. It's really like adds an actual human element to all the statistics that we hear about this, and sounds very scary as a provider. All of those scenarios are terrifying. And yeah, the part about when you had the shoulder dystocia, I didn't even think about like, oh, it's going to take a little bit more time than normal to get a team involved in an emergency because it takes a few minutes to put on PPE.
Yeah. I don't think we realized it either until it happened.
Yeah. Okay. Great. So I'll leave the poll up for a little bit longer. And now I will show you the CE. This has been graciously provided by SEL Health. So thank you to SEL Health for helping us to get CE for these webinars. We really appreciate it. So you can take a picture of this with your phone and get the link. I also have the actual link and I will put it in the chat. Assuming Zoom lets me do it, which sometimes it doesn't like. Okay, yay. Okay, so you can do it on your phone and it's a quick Google Doc, or I just put the link to the Google Doc in the chat, so you can do it that way. Okay, so I'll leave that there for a second. Yes, but I want to thank you so much, Katie. That was such a truly interesting presentation, and the cases were very powerful and tragic, and I think really show the impacts of this. And I think it's interesting too, like some of the things you said, I'm sure were happening at other hospitals as well. that are not rural, but it definitely like becomes clear what you were saying, where you can't afford to have your staff get COVID because you don't have more, or, you know, the patients needed to be transferred to Denver, and that was a big issue. So just really powerful stories that really, I think, do
Yeah.
illustrate the challenges. So thank you so much.
Mhm.
And we can stay on for a couple more minutes to make sure if, you know, anyone has questions about the CE, needs help getting the CE, we can help with that. And if you have any late breaking questions for Dr. Meg Smith, of course, put them in the Q&A, but we'll hang out for a minute or so longer.
Thank you.
Thank you.
For your help.
Corey, I just saw that I just saw your chat. I don't know who Joshua Williams is or why it might say that. It might be that, I don't know if you're on a work computer, but it might be that Joshua Williams is logged in to his Gmail account on the computer that you're on. Because when I click it, it shows like my personal Gmail account as like logged in. So I think that must be what is happening. So if you can click next to the email address, switch account. And you can either log into your address, or it's okay if you don't. And if you can't do it, honestly, because you need to put in your email anyway, don't worry about it. Oh, that's so weird. The speaker is Joshua Williams. Oh. Okay, I know what happened. You can just fill it out anyway, and we'll look at the date. Basically, Joshua Williams was the last speaker, so I think this is actually the wrong QR code link, but we'll be able to see what date the survey was submitted. So we'll know that it's actually for this webinar. Sorry about that. Awesome, cool. Thanks, Corey. Sorry about that. We will make sure that you get the credit that you need. I think we just, I don't know, messed up the link or something today, but I'll make sure that you get it. You get the CD. Thank you. Okay, and I am gonna end the webinar.